OCD is a condition that affects the structural support of the cartilage surface of the bone. And if this support becomes weak or starts to collapse and fail, the cartilage surface, which relies on that support, can break down. If this does happen, that breakdown can lead to loss of joint function, can cause some pain, occasionally some catching, popping, mechanical symptoms, and sometimes swelling, and unfortunately can progress to arthritis in patients as well. A patient of mine a while ago suggested that as we talked about it, they said, it sounds like a bad bruise on an apple. And so I actually have a little apple picture I use sometime to explain how you've got the skin on the apple may still be intact, but the flesh of the apple is bruised. And sometimes if it's a really bad bruise in the apple, the skin of the apple is disrupted, and sometimes a chunk of the apple and the skin will start to fall out. So that's sort of an unofficial explanation for OCD, but there's actually an official technical medical definition, which has been put forth by our OCD study group, or the ROC group as it's known. And it's what we call a focal idiopathic alteration of subchondral bone and its precursors with risk for instability and disruption of adjacent articular cartilage that may result in premature arthritis. When you're looking at an X-ray, you can usually see a clear abnormality of the OCD bone. You'll see the normal appearing bone, and there's typically a gap or a difference in the density of the bone that distinguishes the normal bone as well as the abnormal bone. And it's usually pretty obvious when you look at the X-ray. Here I have an X-ray highlighting that difference, and my arrow will outline the abnormal bone here from the OCD lesion. And then above that is the more normal bone that you would see in a typical OCD case. In the MRI, you get a lot more information because not only can you see those bone abnormalities of the OCD area, but you can also sometimes see breakdown in the cartilage or cartilage changes as well. Here you can see the abnormal bone lesion, and in this case, with this type of MRI, it's a very dark area of abnormal bone. But in addition to the bone, you can also see the cartilage here. The cartilage typically you can't see on the X-ray, and so this is the advantage of the MRI, in that it gives you information both about the bone area lesion here, but it can also give you information about the abnormal cartilage as well. We get asked a lot about healing as a treatment option because in many cases, this can really be effective. We know that kids with open growth plates and those with significant growth remaining, up to 60% of patients will heal with appropriate rest and activity restriction programs. And although 60% healing rate is a good number, you have to realize that about 40%, even with optimal conditions like this, will go on to non-healing. So in those cases, we have to think about doing surgery. For lesions in older patients, or for larger lesions or unstable lesions, even with rest and activity restrictions, typically these won't heal. And so in these types of circumstances, we may recommend surgery as the first choice. A couple of things to keep in mind when you think about proper healing: larger lesions, older patients, the lateral condyle location or the outer half of the knee, or any lesion that has a break in a cartilage. These types of findings usually predict poor healing, and in these circumstances, we're usually going to recommend early surgery to get optimal healing. One thing the ROC study group, ROC is the acronym for the Research on Osteochondritis Dissecans, what this group has learned is that the more data we collect on patient outcomes, this is going to help us devise better treatment protocols, design better surgeries, and also have better prediction tools so we can counsel patients and families about the best type of treatment, whether non-operative or operative treatment, to get the OCD lesion to heal and prevent arthritis. When treating OCD, one of our primary goals is to get patients and kids and families back to the activities we love. We know how important sports are in the development of children, and we focus our treatment protocols on recognizing that. We try to get people back as soon as the lesion has healed adequately to play sports and other weight-bearing activities. Some kids can get back relatively soon, 2, 3, 4 months. Other kids may take 6 months to a year in some cases. But our primary goal is to get patients and families back to the sports they love. And in most cases, we're successful with doing that.